Good evening, everybody. Welcome to the second Conversations with a Doc for 2023. We're so lucky this evening to have Dr. Kelly Mills with us to talk about some of the things that might cause Parkinson's. And I'm going to let him introduce himself, and then he'll talk. And then, as usual, I will ask the questions that you have previously submitted. So thank you, and let's enjoy. Kelly.
All right. So thank you for having me. And let me just make sure my slideshow is visible. If anyone gives me a thumbs up, then I'll know we're good. Okay. Great. So my name is Kelly Mills, and I'm a neurologist who specializes in movement disorders. And I work at Johns Hopkins. I also direct our advanced therapies clinic, which is where we treat patients who really need management of their symptoms, particularly their motor symptoms, with things that are a little bit beyond oral medications. And I also am a researcher, and most of my research focuses on Parkinson's disease and various aspects of it, cognitive impairment in Parkinson's disease, and also using imaging to understand what causes it and what's going on in the brains of people with early Parkinson's. So today, I'm going to try and come close to answering what causes Parkinson's disease. And I just want to start with the caveat that Parkinson's disease is not one disease, and I'm going to try and show you that. But really, you have to just be at a meeting, maybe a MAPS event or a support group meeting or something, and look to your left and look to your right, and it's pretty evident fairly quickly that it's really a heterogeneous condition. Some people start with the symptoms in their 40s, some people earlier, some people start in their 70s, some people have tremor, some people don't. Some people have more cognitive problems like memory issues, others have anxiety, some people have neither. And that really speaks to the heterogeneity clinically, which shows us that it's more than one disease etiologically. And that means, the causes are various as well. So today I'm going to talk about alpha-synuclein accumulation. And then we're going to take a step back and try and understand more of the triggers for that. And talking about genetics and environmental triggers, something called triggers, things that may start the disease, or environmental modifiers, things that may make it progress more quickly or less quickly, and even things, exposures that may alter the course in a good way, or protectants. So the thing that really defines Parkinson's disease in a definitive diagnosis, meaning when you look at the brain under a microscope, is the accumulation of a protein called alpha-synuclein. This protein has a normal function in our brains, but for some reason in Parkinson's disease, we see it accumulate into these clumps. And these clumps are found inside the neurons, which are the brain cells that do a lot of the work in the brain. Specifically, early on, it's inside the cells that make dopamine. And because those cells are dysfunctional and don't produce dopamine, it's assumed that the alpha-synuclein is the problem and is affecting them. So where does this come from? Well, if we go back to a German researcher by the name of Heigl Brock, they looked at pathology, meaning autopsies, in a number of people with Parkinson's disease, and also people where they looked at their autopsy and they found evidence of Parkinson's, but they didn't actually have the Parkinson's disease symptoms. So they had some of this accumulation of protein, but it wasn't enough to cause the symptoms of Parkinson's. And they staged the accumulation of this alpha-synuclein. And so if you look at this figure on the right from one of their publications, the darkness of the shading of this brain indicates how densely distributed this protein is. So it starts down here at the base of the brain, in the medulla, and that's where the nerve from the gut called the vagal nerve comes up and comes into this part of the brain. And so, one hypothesis is that the alpha-synuclein in some people may start start in the gut wall and travel up that nerve into the low part of the brainstem. And when it's here, it can cause problems with constipation. It can cause acting out your dreams, and sometimes it can cause some changes in mood. As it climbs up this brainstem, it finally gets to the midbrain, the top of the brainstem, and that's where it hits the substantia nigra, where these dopamine-producing neurons are. That's when we start to see the physical symptoms of slowness, stiffness, tremor. And then as it spreads to these other parts of the brain, that's when we start to see emotional changes, cognitive changes, and even things when it gets back here, like hallucinations and problems with visuospatial perception. So the spreading distribution of this protein seems to coincide with the different symptoms that occur. In other words, when it affects a certain area of the brain, you get symptoms attributable to brain function in that region. And this has been updated and changed over time. More recently, there's evidence that we may have two entry points of this alpha-synuclein. In other words, in some people, it may start at the brainstem and head up into the higher order levels of the brain. In other people, it seems like it may come in through the olfactory bulb, through the nose, and spread in two different directions there. So that hypothesis keeps getting updated when we have these two different patterns of spread. So if we look at a microscope, through a microscope, and we zoom in, what's happening with this? Well, these red little sticks, if you can imagine, that's the alpha-synuclein protein. And this whole thing down here is a neuron, a brain cell. So actually, it binds to some proteins on the brain cells, and they bring it inside. And once it gets inside, these clumps propagate, and they cause the cells to be sick and even cause cell death. And it actually turns out that there's an active transmission process where they can transmit this from cell to cell, and it propagates along those pathways that I just showed you throughout the brain, if we don't do anything to stop it. And so many of the big breakthroughs in the past 5 years or even 7 years have come in understanding how it spreads from cell to cell and what we might be able to do to stop it by understanding how it spreads and why it spreads. So I told you that the presence of this protein is associated with the symptoms, but we're still trying to explore what that relationship is. And there's 3 possibilities, okay? So in one possibility, we have all of these things going wrong in the cells. Let's just say that there's inflammation in these brain cells, or they're under some type of stress because they've been exposed to an environmental toxin, and it causes misfolding of this protein. And then the misfolding of this protein, that alpha-synuclein, itself is toxic to the neurons, and it lights the fire, and that's what this fire represents. It's really propagating the disease. So there's a toxicity. Another possibility is that that protein that we see there is actually an innocent bystander, that it is the underlying problems with the cells, the stress that they're encountering from genetic mutations or from environmental exposures, is causing the disease in the cells, but it's also causing these protein clumps. But the protein clumps are a bystander. They're not actually causing the toxicity. That's another possibility. And lastly, it's even theoretically possible that the protein alpha-synuclein is accumulating as a reaction to these toxic exposures or these toxic problems in the cells, and that the alpha-synuclein buildup is actually trying to slow down the process. It's a compensatory process, and that's what these icicles represent. It's trying to slow down the process. So this latter hypothesis is now being explored as a loss of function toxicity. In other words, it's been assumed for a while that the buildup of the protein is causing toxicity, but it's also possible that that protein has a normal function. And as it accumulates into these clumps, it can't do its normal job. And we call that loss of function toxicity. Because it's all sequestered into these clumps, the amount of the functional protein goes down, and that itself could mean that the neurons are not functioning properly. And so this actually leads to 2 different possibilities for treatment. So the traditional way of thinking about this is that we need to get rid of this protein. We need to give an antibody or some type of treatment to get rid of this alpha-synuclein. But it's also possible that if the clumps are doing that and they're getting rid of the normal alpha-synuclein, that we actually have to give the brain more normal alpha-synuclein that's not folded into these clumps. So this is a very hot topic and a very active area of research. In fact, we've had some clinical trials where we've tried to remove the alpha-synuclein. But why does the alpha-synuclein accumulate in the first place? So what if we take a step back to try and understand what's even going on that we get to this place? Like, this protein is in our brain and it has a normal function. Why is it clumping up into these Lewy bodies? So it has the answer is probably that there are many different causes of this pathologic process. One of the stories that is now increasingly clear is that there's genetic risk. So on this graph, this really is a figure that I use a lot to explain the genetic risks of Parkinson's. So across the bottom, this is how common genes are in the whole population. So very rare all the way to very common. Going up this axis is how much of a risk a certain gene gives you. Some genes give you a very low risk, but if you get enough of them, you might have enough genetic risk to tip into having Parkinson's. Some genes give you very high risk. In other words, if you get one copy of these genes, it's very likely you'll have Parkinson's disease. Now, fortunately, the very high risk genes you can see are down at the very low or very rare incidence category. So some of these genes, we don't really see that much. We see them occasionally, and they're very rare. When we do see them, they usually march through families, like every generation of a family has someone with Parkinson's disease, or it's autosomal recessive and we see it skip generations, but it's definitely in the family. Some of these very high-risk genes like PINK1 and Parkin cause early onset Parkinson's disease. So onset can be in the 20s or 30s, something like Michael J. Fox. There are medium risk genes. They're about, they're moderately common in the population of people, and they confer a medium risk. And then what's more common in a lot of our patients are low risk alleles that are very common. So if you have low risk gene mutations that are very common, how does this work? Well, up here, you may just need one gene mutation and you get Parkinson's. Down here, you probably have a couple gene mutations from your mom, a couple gene mutations from your dad, and unfortunately in you get enough that you have an additive risk score from these gene mutations that may tip you into Parkinson's. And they may make you susceptible to some type of environmental exposure. I'm going to talk more about that. And the interaction between having these genetic risk factors and the specific environmental exposures may initiate the process of Parkinson's, and then you get that alpha-synuclein starting to accumulate, and that furthers the process. So how do environmental triggers factor in here? So, if we think about this as the timeline of Parkinson's disease, so even at age 0, right, you're born with genetic risk. You may have some environmental triggers that could start this process of slow protein accumulation even early or midlife. Those could be air pollutants, pesticides, viruses that cause inflammation in the brain, and other things that we haven't yet discovered. They interact with the genetic predisposition that one individual already has to start this process. Some of the earliest symptoms are loss of sense of smell, constipation, issues with sleep, depression, anxiety, other non-movement issues. And then eventually you develop the movement issues like slowness, stiffness, and tremor. And that's what typically leads people to see a neurologist and get a diagnosis. But by the time that happens, a lot of this has already been going on for decades. So I'm going to talk about some specific environmental triggers here. We'll talk about some pesticides in general, and then I'll give a few specific examples, and then a few other things like even traumatic brain injury. So I like to start with this study. This is a really big study where they looked at 184,000 people who were followed over time. And they did what's called an exposome. So they took detailed accounting of everything that people may have been exposed to. They gave them in-depth interviews about different types of jobs they did, places they grew up, things they may have been exposed to if they lived on a farm, and looking at pesticides, asbestos, chemicals, solvents, coal, dyes, formaldehyde. The thing that really shows the statistically significant increased risk is pesticides and herbicides. None of the other exposures in this big study showed an increased risk of Parkinson's disease. And that's right there. So for these people, those exposed to pesticides or herbicides 10 years before the start of the study had a 70% higher incidence of Parkinson's disease 10 or 20 years later. So there's definitely some association there. And there have been other studies that try and account for other things that would explain that. Well, you could say, well, what if the fact that you're getting exposed to pesticides and herbicides, what if it just means that you're living in a rural setting and there's other things in the rural setting that are really the cause or the trigger for Parkinson's? And they've done studies to try and account for those and adjust for those. And those studies still show that pesticides and herbicides are a risk factor. So they look at studies like, this specific study went and looked at the exposures of farmers, right? So farmers live in rural areas. They would be exposed to a lot of the same things that farmers who are using pesticides and herbicides are exposed to. But the farmers who are not exposed to pesticides that still lived in that same setting and had all the other exposures, they didn't show an increased risk of Parkinson's. So that kind of accounts for the living situation and other things in that setting. In a different meta-analysis, which just means a study of studies, so combining a bunch of different research studies together, Parkinson's disease risk was 90% higher in people exposed to pesticides and herbicides. And most of the research here, at least in North America, really comes from the Central Valley. So if you're not familiar with the Central Valley, it's really considered, America's salad bowl. A lot of the produce that we eat, whether it's vegetables, almonds, fruit, a lot of it comes from the San Joaquin Valley in California. And so it's a really great place for studying this exposure, unfortunately. So if you look at each of these, if you separate out by counties, so there's a lot of counties in California. If you look at the counties that have over 37% of their acres sprayed. So over a third of their acres are sprayed with pesticides and herbicides because they're really farming areas. There's a 2.5-fold increase in Parkinson's disease in those counties compared to neighboring counties where the spraying rate is lower. But it's really important to know not everybody that lives out there gets PD, right? I mean, these people who are living in the Central Valley of California, there's many people who are doused in this stuff all day or around the pesticides and herbicides that never get Parkinson's disease. So it can't just be the environmental exposure, right? So we think of it as the environmental exposures, and there are others. It's not just pesticides and herbicides. Also, inflammation is a big one. I'm going to talk about that too. But you combine that with a genetic risk, going back to our idea of genetic risk. And that's what gives you an increased risk of PD, is starting that process early on in the brain. So this is an example of a combination of the two. So if you look at the fungicide Maneb or paraquat, the herbicide, you may have read a lot about paraquat and Parkinson's. So there is an increased risk of people with getting exposed to Maneb or paraquat having Parkinson's disease. But what's really interesting is if you look at if you look at a large group of people and you look at a gene for an enzyme that creates antioxidants, these are chemicals that fight the negative effects of pesticides and herbicides, specifically these two antioxidant genes. People with a bad variant where it makes the protein not very good at breaking down the herbicides or pesticides or dealing with the oxidative stress caused by the poisoning of the cells caused by these pesticides and herbicides, those people have a much higher risk of Parkinson's. Other people who have a genetic variant that makes them really good at dealing with these oxidative injuries, and they make a lot of antioxidants in their cells, those people, they don't really have an increased risk of Parkinson's, even when they're exposed to the paraquat and mannab. So it's really only the people with this problem with making their own antioxidants that have an increased risk under this exposure. So this is just an example of combining the environmental exposure and genetic risk. Another example is organophosphates. So you've probably heard about these before. They're a pesticide, and they're very effective. And it turns out that we have a gene in us that'll break these organophosphates down, the PON1 gene. So if you look at a big population of people and you look at their genotype for this one gene, the people who have a really good protein made by this gene that breaks down all of that toxin, breaks down that poison very quickly, they don't have an increased risk of Parkinson's, even if they're exposed to organophosphates. People who have a different form of this gene that makes them slow metabolizers, where they're not as good as breaking down the organophosphates, they have an increased risk of Parkinson's when they're exposed to organophosphate. Now, these slow metabolizers alone, if they never get exposed to organophosphates, they don't have an increased risk of Parkinson's disease. So it really is a two-hit problem here: genetic predisposition and potentially environmental triggers. And so there's another story with air pollution. So why do we find in mice models and in humans that alpha-synuclein often can start seeding in the olfactory bulb in the nose? That may be a point of entry, meaning that whether alpha-synuclein, is a byproduct or whether it's the active toxic thing that's affecting the cells in Parkinson's disease, it tends to start in the olfactory bulb is one of the places. So why does the process start there? Could air pollution contribute to Parkinson's risk, or something that we're breathing in all the time? And it actually, interestingly, if you look at a map of the United States and you look at the per capita incidence of Parkinson's disease, it really follows industrialization. So you see it along the East Coast, you see it in Ohio, in the Midwest, in the industrial Midwest, you see it out on the West Coast. You don't see it as much in rural areas. So that's adjusting for the number of people. The per capita incidence tends to follow industrialization. And there have now been a couple studies looking at traffic air pollution increases PD risk in a study done in Denmark. A similar finding was found in a study done in Taiwan. So it's been reproduced. And then we have the story of inflammation. So there was a pretty big study published, I think it was in 21 in JAMA Neurology, and they went back in a country in a Northern European country, and they had, they have a socialized healthcare, so they have records on everyone. They can track everyone's exposure risk more easily and their outcomes. And they found that people who had a prior influenza exposure 10 years or more before, looking back 10 years or more, they had a much higher incidence of Parkinson's disease than people who never had an influenza exposure. Also, people with ulcerative colitis or inflammatory bowel disease also have a higher PD risk. So now we're combining the inflammation also with the inflammation specifically in the gut wall, going back to that hypothesis of potentially the alpha-synuclein accumulation starting in the gut and traveling up the vagus nerve. This also interacts with that hypothesis to kind of put together a story where maybe people who have leaky gut or inflammation in the gut, maybe as a consequence of gut dysbiosis or an inflammatory disease, they have the cell injury starting there. And then there's been some epidemiologic studies as well that kind of support this idea indirectly. So it turns out that people's total lifetime NSAID use, so NSAIDs are things like ibuprofen, meloxicam, diclofenac, things like that. The more NSAIDs people use, the lower their Parkinson's risk. Maybe because if inflammation is associated with activating the immune system and that somehow triggers Parkinson's disease, that even just taking anti-inflammatories for like an injured knee or something also reduces the risk of that brain inflammation happening and Parkinson's getting triggered. So it can work both ways, though. So very interestingly, we find that people who are smokers have a lower incidence of Parkinson's disease. Now, there are many different hypotheses as to why this is the case. Some people think that since smoking introduces a kind of something we usually consider a negative thing, carbon monoxide into the brain, that since you're slowly introducing carbon monoxide to these cells, which puts them under stress, that it might prepare them to ward off a higher stress like Parkinson's disease. And almost it's like taking your brain cells to the gym, so to speak. Having them do a little bit of a workout is somehow preconditioning them to be able to resist Parkinson's. I don't know that there's a ton of human evidence for that, but in some animal models that's been proposed. And there's even a new clinical trial where they're considering giving people carbon monoxide. It's not thought that the nicotine itself is really protective. It has shown that in some animal models, but there was a randomized clinical trial with hundreds of people in it where they gave people with early Parkinson's nicotine and they couldn't slow down the progress or alter the course. But is the nicotine a trigger for starting it, even if it doesn't change the course? Maybe. But reverse causality has been proposed. And so when you hear that smoking is protective against Parkinson's, it's from a researcher standpoint, it's not really true to say that because we haven't proven that it's causal. Smoking is associated with a lower risk of Parkinson's disease, but it could be that when Parkinson's first starts, decades before it manifests, that it somehow reduces the risks that someone would be a smoker. And there's actually a hypothesis saying that maybe if Parkinson's starting at a very early stage in life, decades before you get the symptoms, if it decreases the dopamine that is involved in addiction, that it makes people less likely to be addicted to things. And so maybe that's why they have a lower incidence rate, or they quit cigarettes more easily than people who don't have undiagnosed early Parkinson's disease. There's a couple different explanations for this. Higher caffeine consumption is also associated with a lower risk of Parkinson's disease. Again, the mechanisms for that are not completely clear, but there are some hypotheses as to why that is the case. Overall, I think caffeine can be helpful for treatment of some symptoms of Parkinson's, like fatigue. It certainly doesn't help dehydration and low blood pressure, but it has been noted to be associated with a lower incidence of Parkinson's. Also, gut microbiome and inflammation abnormalities have been shown to be associated with PD. So certain healthy diets that promote a quote unquote normal or non-inflammatory gut microbiome can decrease the risk of Parkinson's. So the microbiome is the mix of different types of bacteria that live in your intestine, right? So you have to have these bacteria to live. We're symbiotic with them. They help us break down certain nutrients and absorb certain things, but there are some that are better to have and some that are not as great to have. And some of that's dictated by our genetics. Some of it's dictated by from day one, the first time we breastfeed, we start to seed that lining with our parents' bacteria. And some of it is dictated by our diet. So what are some protective exposures? Now, I've been talking about things that cause Parkinson's disease, but what about things that are protective? So we know that early, meaning exposures early in life that may decrease the risk of Parkinson's later. So it's been shown that physical activity may be protective in some people. So there's a pretty big study of almost 50,000 men and 77,000 women. And they found that in men, higher physical activity earlier in life lowered the risk of Parkinson's disease by 30%. And if it was strenuous activity, like high intensity workouts or things where you're really getting your heart rate up, that it was a 60% lower PD risk. Now in women, they found that higher physical activity was not necessarily associated with PD risk, but if they did strenuous activity early in adulthood, that was associated with reduced Parkinson's risk. So why is that the case? I don't think we have a good explanation for that. There are many studies that are trying to explain this, such that, if you could take whatever physical activity is doing and put it into a pill or put it into a syrup, there'd be a lot of people interested in taking that and a lot of people interested in making that. So how do protective exposures potentially work? So if we look at people with a moderate risk gene for Parkinson's, something called LRRK2, which is probably one of the most common genetic inheritance forms of Parkinson's that we see in families. It's a medium risk gene, it's right here. So if we look just at those people, and we know that the LRRK2 gene encodes a protein that is involved in the inflammatory pathways, in the immune system activation that happens in the brain. Now, that immune system activation is supposed to keep our brains free of infection. But if we look at NSAID use in these people specifically with this gene mutation, if they have a high NSAID use, like of Advil or Motrin or Aleve earlier in life for other reasons, that it really reduced their Parkinson's risk by up to 70% compared to people with the same gene mutation who weren't using those medications. Now, I'm not telling people to go out and use these medications if they don't have a reason to, if you already have Parkinson's, but it really tells us, it gives us a lot of clues about what may be going on pathologically early in the brains of people when this is starting. So just to kind of circle back, so pesticide or air pollution exposure may increase the risk. Not everyone with these exposures gets PD. And genetic variants interact with those environmental exposures to increase the risk of onset of PD. And then once that onset starts, there's the accumulation of this alpha-synuclein protein that is found spreading throughout the brain in a way that correlates with some of the symptoms that occur. So when it comes to exposures, I feel like I can't give a talk on this without saying, okay, so we talked about this, you have PD, now what? And so we can look at it from the other perspective of like, what are some environmental modifiers or protectants that we can take advantage of, right? So, and what I mean by that is if there's different phases of Parkinson's, there's pre-symptomatic, early non-motor and motor symptoms. We have the onset of symptoms, and this whole time our dopamine levels are going down. And it's not until they're pretty low when we start to get these movement symptoms or motor symptoms like tremor, stiffness, slowness, and imbalance. And what we want to do is understand these mechanisms that we just talked about enough to shift this curve, right? We want to shift it to the right so that those dopamine levels are not going down as quickly, and we can shift everything over so the symptoms don't start until later in life. And if they do start, there's a slower increase in symptomatology. And that's called disease-modifying therapy. Protecting the neurons is called neuroprotection. So can environment change the progression rate? So it can. So there are exposures that can worsen it, but it has been shown that better diet quality equals less death from Parkinson's disease. That's been shown in a pretty recent study. And so what they did was they surveyed people on their diets, and they binned them into the things that were a protective effect and things that were a negative effect on progression rate over time. And they showed that things like sugar sweetened beverages, fruit juices, red or processed meat, trans fats, sodium, moderate alcohol increase the rate of progression. And the things that all of our doctors always tell us we should eat more of decrease the rate of progression. So if we had to pick one diet, probably right now, there's no good evidence that one diet is better than the other, but taking the study, the findings from this study, the thing that's closest to that diet is probably the Mediterranean diet. So that's a way to modify your disease course over time, something that you can do to change the course of your condition. Physical activity over time, we talked about it as a risk factor for starting PD, but once you have it, people who are the most active when they do a study of different activities levels are 30% less likely to die than people who are least active. And if we look at a whole bunch of different things that are potentially helpful in slowing disease progression, the things that really pop out are circled here in red: caffeine, liquor at certain low amounts, competitive sports, smoking. They change the risk in different directions. And finally, I always have to show this slide of exercise. So it is proven in a clinical trial that if you randomize people to exercise with moderate or high intensity compared to usual care, which might be their kind of walks or maybe no exercise, that the people who are doing the exercise, even after 6 months, you can detect a slowing of their disease progression if you keep monitoring them closely. So this is my conclusion, and been talking a while and a little bit long, so I'll just stop there. Okay, Judy, I think you're muted.
Now, okay, so thank you very much. And now I've got some questions from people, and we had two questions in the chat. So let's do that first. What is the connection of this protein and the sleep challenges of PD?
Well, there are many different sleep challenges. So there is dream enactment, and it's shown that when the protein climbs up the brainstem and reaches a part of the brainstem called the locus coeruleus, that it releases the body from being paralyzed during dreaming, and people start acting out their dreams. There's also sleep fragmentation, and also when it climbs up the brainstem and reaches centers that are involved in sleep-wake cycle, there can be a fragmentation of sleep where instead of staying asleep the whole night, people are having frequent arousals, and it's really hard to stay asleep. So those are the main, I think, effects on sleep. There's also other body systems that are affected by Parkinson's that also affect sleep. So for instance, the protein accumulating in the lower parts of the brainstem and the frontal lobe can also change urinary frequency and make people urinate more frequently, which is going to affect your sleep overnight as well.
And the next one is, will we get the doctor's contact information? So I'll leave that one for you, Kelly.
Yeah, so our contact information is our main number, which is our help. We also have, we have a helpline where we can answer questions, is 410-502-0133.
Okay. What is the best approach for medicating a person who has Parkinson's and high blood pressure and NMH at the same time? I've been told that beta blockers are not the best suggestion.
What's NMH?
Orthostatic HYPOTENTION.
Oh, NOH. So it's a very tricky situation. What I would say is our general approach is that hypertension or high blood pressure mostly gives you a long-term risk of bad things. So it increases the risk of having a stroke, it increases the risk of having a heart attack, but those are long-term risks. And most of that risk comes from having high blood pressure in midlife. If you're later in life and you have high blood or you have orthostatic hypotension where your blood pressure is dropping when you stand up, that's again a long-term risk. The short-term risk of orthostatic hypotension is much more significant. Orthostatic hypotension can cause you to pass out and fall and injure yourself. You could break a wrist, a hip. You could get hospitalized. It's a really short-term risk. So I tend to value treating orthostatic hypotension more aggressively and letting the blood pressure go up when the person is sitting or lying down. That's called supine hypertension. And that's often a problem when we give medicines to boost up the blood pressure. It's going to make the seated or lying down blood pressure higher. In some cases, if that lying down, the supine blood pressure is very high, we may have to give a short-term medication like a short-acting beta blocker at night when they're laying down, if we don't want them laying there all night with high blood pressure, or other short-term antihypertensives. So it's a difficult situation. We always start with non-pharmacologic treatments. People don't like to do it, but drinking a lot more fluid and eating more salt is helpful. And also compression stockings that come above the knee and even abdominal binders are treatments that are non-pharmacologic and that treat the orthostatic hypotension without increasing your blood pressure when you're sitting or lying down.
Okay, does eating non-organic apples cause Parkinson's disease? And would peeling them make them safer to eat?
I can't speak to the risk of just apples. What I can say is that if you, most of this talk was about what starts Parkinson's. What we don't know as much about is once you have it, what is being exposed to these things do? And I don't think there's as much research on that. But if you're talking about the risk factors for Parkinson's, I think any pesticide exposure that you can reduce theoretically would reduce your risk of developing Parkinson's, especially if you are at a high risk for it, like if you're in a family that has a lot of Parkinson's. So I think eating anything organic is going to be probably safer. Probably, and I hate to say this, but there is a study out of Hawaii showing that one of the highest risk things that people consume is actually milk, because if you think about it, animals like cows are eating a lot of products that may have pesticides, and then they concentrate that in their milk. So dairy products are potentially pretty high risk as well. And there was a study showing milk intake was associated with the risk of Parkinson's. So, I mean, I wouldn't make it specifically about apples. I would say when you're eating an apple, I mean, some of the pesticide penetrates it and it's really absorbed by the plant overall. I don't know that skinning it or washing it is going to really change that risk that much. On the other hand, it's probably better to eat healthy and eat apples rather than processed foods and basically processed foods and meats overall, even if you are eating non-organic food, because organic food is really expensive and it's almost impossible to eat. Well, for a lot of people, it's almost impossible to eat an entire organic diet. But sticking toward the Mediterranean diet is still, even if you're not doing it with organic foods, is still technically is probably going to give you a lower risk of Parkinson's onset.
3 of 4 close college friends of my husband's all have Parkinson's. Would that be considered a cluster worth investigating?
I think that it's probably a cluster. I don't know that the investigation is, whether or not the investigation would be done by a scientist and whether it would further anything, I'm not sure. There are people who do that type of epidemiologic research where they go around looking for clusters, and then they look for some type of common exposure, and then they explore the genetic risk factors in those people, and they try and understand how that exposure combined with those risk factors. So yeah, I mean, there are different stories and outbreaks of Parkinson's disease in different regions. There's something called Guam Parkinsonism that's been associated with the intake of certain fruit like pawpaw. And there are toxins that do lead to these clusters.
Are men more likely than women to get Parkinson's?
So men do have a higher incidence of Parkinson's disease. I don't think that's fully understood why. The gap has closed. It used to be that, research in the United States, research in general in the Western world was mostly done in white men. So as research has been a little bit better about trying to proportionately understand the disease in women and in people of other genetic backgrounds, that gap has actually closed between men and women. I think what I'm saying is a while ago it was thought to be much higher in men because those are the people under research or who are being researched and treated, and now that treatment is more available to everybody, we know that the gap is a little closer, but it still is a higher incidence in men. There are certain ethnicities that are associated with a higher incidence. So, people with an Ashkenazi Jewish or Eastern European Jewish background have a higher incidence of some of the genes I spoke about, like LRRK2 and GBA. And so we see certain enrichment in some specific populations from around the world too.
Anxiety and depression from a young age. Are these risk factors for Parkinson's, and is there a Parkinson personality?
The Parkinson's personality is, I would say, controversial. Some people, when they look at personality inventories, there's been some association between, measured higher scores of neuroticism and certain personality traits with Parkinson's. But there's a lot of selection bias and there's a lot of bias in that research. So I'm not a huge proponent of that idea. Anxiety and depression at an early age is not necessarily associated with Parkinson's. The higher risk for Parkinson's is late onset anxiety and depression. So if you're going to have major depression, major depressive disorder, or anxiety disorder like generalized anxiety disorder, it usually starts at a pretty early age. It's often starting in someone's 20s or maybe 30s or maybe their teens. If you see someone who never has any psychiatric symptoms and then all of a sudden in their 50s starts to have anxiety and develops panic attacks, those are the people in whom, when we look back, we say, oh, that was Parkinson's starting. And it's affecting the mood regulation parts of the brain as an early symptom, even before the tremor started and before they got a diagnosis.
I believe that a drug that used to be prescribed for anxiety or depression is now seen as a possible cause for PD. Is that right? As I recall, it had a name like Menoril or Melloeril.
There are medications that have been that are associated with Parkinson's risk. I'm more familiar with research showing that antipsychotics are associated with Parkinson's disease risk. It was once thought that antipsychotics could give you side effects that mimics Parkinson's disease, and that's very true. And many of those people, when we stop the antipsychotic, the Parkinsonism goes away. But there's also some epidemiologic data suggesting that antipsychotics may actually increase the risk of Parkinson's disease itself as well. Melaril is, I believe, an MAOI that is no longer used. And my understanding of the MAOI class is that it's actually protective against Parkinson's. But I'd have to look up that research specifically for Melaril. It's not a drug that's in use, at least in the past few decades, it hasn't been in use really.
Is there any thought of splitting up Parkinson's by features to address the issues? Not much progress would have been made in cancer research if breast cancer was not segregated from colon, prostate, etc. I know of a few symptoms that are different in Parkinson's patient. Sense of smell and constipation are two.
So we don't divide up the patients to treat them. The patients have different combinations of symptoms. So I kind of think of Parkinson's almost like I call it a smorgasbord of symptoms. And, some people have constipation, some people have, tremor, some people have cognitive impairments. Not everyone has all of them, usually not. So in any one individual, it's usually a combination of different symptoms. But when it comes to trying to develop treatments to stop or slow the progress, we are absolutely trying to divide up patients. We're trying to come up with tests or biomarkers for those underlying mechanisms, and to be able to separate people into groups that might respond to different drugs. So, for instance, soon our center will be starting a clinical trial for people with a GBA mutation. So the treatment that has been developed only for people with Parkinson's caused by a mutation in the GBA gene. There are other clinical trials that are ongoing now only for people who have Parkinson's with a LRRK2 gene. There will be other conditions in the future where there's only treatments being given to people who have an evidence of neuroinflammation as a trigger of the Parkinson's, like from a virus or something like that. So we're trying to divide people by the underlying mechanism that started the Parkinson's in order to give them the treatment that best addresses that mechanism. Because so far, the clinical trials that have been done to slow or stop Parkinson's, they've just put everybody together and then given them a drug that they think it'll work on everyone. But we know now that the mechanisms of Parkinson's starting and progressing might be different from person to person. So that approach is called personalized medicine, and it's a lot of the research that we do at our center.
Do heavy metals, I think you might have addressed this already, but do heavy metals and other toxins, i.e. pesticides, Agent Orange in Vietnam, plastics, etc., have they been found to cause Parkinson's? And have there been studies to test this, especially heavy metals found in the body of those with PD?
So heavy metals, really not as much. There's not as much of a strong story here. And I think for the pesticides and herbicides, I gave multiple slides on that. So that I think I answered that as a definite yes.
Genetics. My father had Parkinson's. Environment. The family had well water. The patient worked on a farm as a child and a teenager and was exposed to chemicals. The patient worked in a nursery as a teen and young adult, exposed to chemicals. How do each of these relate to a Parkinson's diagnosis?
Yeah, so I think we covered that, right?
Yeah, I think so.
In a lot of depth there. So, I mean, definitely there's some exposures, and not everybody that has those exposures gets Parkinson's disease, but people probably with a genetic predisposition, if they do get the exposure, then they have an increased risk of Parkinson's.
And I think you've answered this one as well. Can DDT exposure years ago be a possible cause of Parkinson's?
Yes, potentially. Yeah, there are DDT and Agent Orange they have in some of the things that were just mentioned in these questions have some specific studies that have been looking at them. So DDT is probably a little bit more, I think the worry is more as a carcinogen. But it has probably some Parkinson's risk as well.
How do you decide how much carbidopa levodopa should be prescribed to minimize or control the proper amount of dopamine?
It's all based on the symptoms. So the symptomatic treatment of the movement symptoms like tremor, stiffness, and slowness, you titrate the medication dose to cover up the symptoms. So the example I use is like if you have pain, let's say you have knee pain. If you take one Tylenol and that doesn't help the pain, then you take 2 Tylenol. And if 2 Tylenol pills helps the pain, then that's the right dose for you, right? If that doesn't help the pain, then maybe you take something stronger. So that's the same approach to dopamine replacement. If the dose you're on isn't helping, then it's not worth taking. You either go up on the dose or you try a different medication.
Can you clarify what you said about moderate alcohol consumption? Is it good or bad?
Yeah, so there have been studies showing that certain levels of alcohol exposure might be a PD risk factor for starting the disease. Once you have Parkinson's disease, what's the effect of alcohol on the rate of progression? That might actually be in a little bit of a different direction, and it might also depend on the type of alcohol. So, even 1 to 2 liquor drinks daily is probably not good for rate of progression. Red wine may be an exception because, as I'm sure everybody on this call has heard, there are some benefits from some of the chemicals in red wine, like antioxidants and resveratrol, that maybe offset any direct toxicity from the alcohol molecule itself. And so that may be an exception. But so I think, when someone already has Parkinson's, I think there's not, overwhelming evidence that you shouldn't have any alcohol. I personally, I usually tell people that we still want them to live and have a good quality of life. And if, having an occasional drink or, maybe a glass of wine a night or something like that is part of their quality of life, then I'm not going to fight them on that.
Can the doctor please repeat the phone number that he gave earlier? Oh my God, I've lost the question. Can you repeat the phone? Oh, and do you take private patients?
Do I take private patients? Well, I take personally. I mean, we have I think everyone here is kind of, we're living in a region, fortunately, that has a number of movement disorder specialists that are all great. We have 8 different doctors at our center alone. And in our number, we do take patients. I will say that sometimes it can be a little challenging to get in and join a practice, because if you think about it, when we take a patient, it's not like we're a surgeon where we take a patient, we fix a problem, and then that's it. When we take a patient, it's usually like a 15, 20-year relationship. It's really like a primary care doctor relationship. And so if the clinics are full, it's because there are so many patients who need help. And so our phone number is 410-502-0133.
And let's see, some of these questions don't have anything to do with the topic, but I'll ask them anyway. Are there devices or ways to enhance accessibility of mobile phone keyboards, which are so small?
So yes, there are projection keyboards that can project a light-based keyboard onto a desk. There are kind of advanced things, like things you wear in your hands that sense the keyboard strokes that you're doing. I really encourage my patients to use their dictation on their phone. So most of the new phones are really getting better and better at understanding you, even if you have an accent, or even if you have some changes in your voice volume or your speech from the Parkinson's itself. I think they're getting the artificial intelligence that is taking the words and trying to decide what is the most likely thing you said is getting better and better. So I really encourage to just push patients to push the button to talk to their phone. Like on an iPhone, it's just you push the main on-off button and you talk and you tell it what to do. Like, draft an email to Judy to say this conference was great and I had a wonderful time. Signed Kelly Mills, and it'll just write the whole thing. And then you say send it and it'll send it. So they really do a lot more than people realize. I realize that if you have voice difficulties, it can be a challenge, but I think they're getting better and better.
My husband's doctor increased his carbidopa-levodopa to address increased tremors. Surprisingly, he suddenly had almost no problems walking, even though the tremors did not change. What explains this? Because previously nothing, all in capital letters, helped his walking, gait, tripping, and falling.
So this is something that we see pretty commonly. The different movements symptoms respond to different doses. So sometimes we have a patient where, let's say they're taking carbidopa-levodopa, let's say it's a 25-100 pill, and maybe two pills at a time, 3 times a day, really helps the slowness and stiffness, like the problems walking and the stiffness and posture and things like that. But the tremor, a lot of times, takes a much higher dose. And sometimes the dose of that the tremor requires may be double what the other symptoms require. And a lot of times the patient can't even tolerate that high of a dose to get the tremor to go away completely. So we have to use different medications for the tremor, or we have to use other advanced therapies like deep brain stimulation or other things like that are really good at treating tremor, even if the tremor doesn't go away with the medication. So the short answer is the different symptoms respond to different doses, and the slowness and stiffness often respond to a lower dose than the tremor does.
What is I think you might have answered this one too. What is the connection of this protein and the sleep challenges of PD? I think you answered that.
Yeah, that was the first one.
Yeah. There was a question here about, is this session going to be available on Zoom? And I'll just tell everybody that all the sessions are available, are recorded and are available on our website. So every conversation with a doc that we've done from the beginning of the series, 2 or 3 years ago, is on the website, which is, what is it? www.marylandparkinsonsupport.org. It's good, I know that by heart. So I thought the cause was unknown, but my husband was around chemicals when they would spray neighborhoods in New Jersey for mosquitoes. So I guess the question is, could that be the cause?
Could be.
We answered that one. Is there a benefit to Parkinson's patients using an eye watch?
It really depends on what the issues are. So that's a pretty complicated answer, to be honest. I mean, so I have some patients who benefit from different things with one, and it doesn't have to be the iWatch specifically. There's a bunch of different brands, but if you have trouble remembering the times of your doses of medication and you put alarms on your phone, those are going to ring on your watch. So no matter what you're doing, if your phone's in your pocket or not, your wrist is going to be buzzing you when it's time to take a pill out of your pocket and take a dose. If you're trying to increase your total activity level, there are many different programs that motivate you and help with your tracking of your steps or your activity level during the day. And I think I have some patients who find that motivating and find it as kind of like a personal challenge, or just helps them keep track of their steps. If they haven't done enough activity for the day, they look at it and they think, okay, well, I need to go out and walk the dog one more time or something like that. So I think that can be helpful. There are some symptoms that are specifically designed around tracking your symptoms. I think if it's helpful to you and if it's helpful to your doctor, and if it facilitates the conversations about the symptoms that you're having so that your care team can provide better care, then it could be helpful. Some of the apps may just provide so much information, it's overwhelming. Because what your physicians really need to help you the most is really a summary. Like, on average, I don't need to know what's happening to you every minute of every day. That's just too much information to go through. If you can use the app or use a diary to give me an idea of when are your good times, when are your bad times, does the medicine work at certain times or not at other times, when are you having certain symptoms, that's going to help your care team tailor the treatments.
My husband's diagnosis changed to PSP in the last 6 months of his life. How does that condition fit into this spectrum of neurological conditions? He never responded well to levodopa in terms of decreasing his symptoms. What is the help for PSP?
So PSP is called progressive supranuclear palsy. And that name means that there's eye movement abnormalities. So that there are things that PSP shares with Parkinson's that have some similarity in their symptoms, but there are many things that are different. The main things to remember about PSP that are different is that one is that balance issues in walking begin very early. They're often there at the beginning of the disease, whereas usually people with Parkinson's disease aren't really developing balance issues for many years, to the point where they're stumbling or needing to use a walker or falling. On PSP, it happens very early in the classic form. And they also have eye movement abnormalities early on, where they can't move their eyes up or down. And this also makes walking more difficult because they have a harder time seeing what's in front of them. And also, they tend to have some significant cognitive problems earlier on in the course that increases their disability faster than in Parkinson's disease, where if there are cognitive issues, it's usually not right at the beginning, and they usually take a slower course. So in general, PSP, the classic type, there are different subtypes of PSP, but the classic type of PSP is usually a more aggressive form, aggressive disease, and people have a more rapid progression of disability, unfortunately. Because it's not solely due to a dopamine loss, they don't tend to respond to dopamine replacement medications as well. So a lot of the treatments are based on trying to use different therapies to improve balance, improve cognition. They may use some cognitive enhancers and treat any of the mood or behavioral issues that can come up with it. There's a subtype of PSP called PSPP. Doctors like their acronyms and they like to confuse everything, but there's a subtype of PSP that really looks like Parkinson's in the beginning. That's why it's called PSP Parkinsonism or PSPP. And that type can often be misdiagnosed as Parkinson's disease early on, but then as it progresses, it becomes more clear that it's PSP.
So we have a couple other questions, but basically you've addressed them already. I think that is it. I want to thank you for coming, but you wanted to talk a little bit about something that Hopkins is going to be doing later on.
Yeah, so I just wanted to thank you, Judy, for having me, and for setting this up and giving me the opportunity. One of the things that we're always trying to do is we have a number of community outreach programs and educational series to try and teach people about their conditions. And then we hold some seminar and symposia. We have one coming up on May 13th that has a real focus on holistic wellness. So rather than being a bunch of lectures about medications and lectures from physicians and such, it's a lot of other types of allied health providers. So different types of therapists, different types of exercise professionals, dietary professionals, the other treatments of Parkinson's other than just medications, to try and focus on a more well-rounded treatment plan. And so that's going to be at the DoubleTree in Pikesville, and I will send a link to Judy in case she wants to, make that available. Or
I will.
yeah, I can put it here in the chat if you want me to, and just drop it. It's up to you.
Sure. I mean, but send it to me as well, because I will certainly put it in the newsletter.
Yeah, so that might be helpful for some people here. I think we're space is a little bit limited there. It is kind of big, but we're using our fundraising and stuff to try and put this on. So it's going to be free. So we have to kind of limit the number of people we can fit in.
Understand. Are there any, did I get everybody's questions for the most part? Let's see. I don't know how appropriate this one is, but somebody asks, will you be in Hagerstown on April 6th for our support group? Did you know about that?
Yes, I did. I had a patient remind me today about it, actually.
Okay. And you will be?
Yes, I'll be there.
Okay.
As long as there's some free lunch at the Western Sizzlin.
Oh, here's a new one. As a leadership member, how can I get more of our members to a movement disorder specialist? I still have a few who just see a PA.
Well, I would say that the title is actually a little less qualifying than the actual experience and reputation. So for instance, I work with a nurse practitioner who only sees Parkinson's really in essential tremor, and I'd send my mother to her. I mean, she's one of the most amazing people I know. So I think there are a couple ways, though. You can go to the Movement Disorder Society. If you just Google Movement Disorder Society, and most people that are neurologists trained in movement disorders are listed there. There are movement disorder specialists at the major academic centers like University of Maryland, Georgetown, Johns Hopkins, but there's also a lot of really good movement disorder specialists who are in private practices or neurology group practices in the community. Many of them in our region are that way. I think that the Movement Disorder Society is probably one of the good places to go for that information. Also, the Parkinson Foundation lists a number of people. They have the Centers of Excellence, but then they also have just other people who have registered with them.
Okay. I think that's it for all the questions. Kelly, thank you so much for doing this evening. I mean, I know that everybody enjoyed it and found it useful because I see some of the comments, and I did too. It's been great. Thank you so much.
All right, thank you.
Now you can go play with your children.
Fortunately, they're already asleep, so I can start on work. But thank you, Judy, and to MAPS for doing everything you do for the Parkinson's community.
You're welcome. Thank you.
Take care.
Good night, everybody.